and welcome. I'm Darren Gordon, former Medicaid Director for the state of Tennessee and a founding partner of Speire Healthcare Strategies. Speire Healthcare Strategies is a boutique healthcare consulting firm and a key partner for the NORC MCO Learning Hub. The NORC MCO Learning Hub is committed to providing information on ways to address health equity and transform healthcare with a focus on MCOs, consumer groups, state Medicaid leaders, and other industry experts. The Hub is hosting a new 6-part quarterly webinar series highlighting innovations in Medicaid, and this is the second webinar in that series. The webinar series will include national experts discussing the latest trends, initiatives, programs, and findings on timely topics important to improving the Medicaid program and meeting the needs of Medicaid beneficiaries. The second in this series is centered on the challenge pace and determining how to best integrate to meet the complex needs of dually eligible individuals, effective strategies for better integration, and how to implement those strategies. Now, before we get to the agenda and introduce our speakers for today, I wanted to note that all attendees will remain in listen-only mode, but please send us your questions using the chat box, and we'll get to as many of those as we can during the webinar. You can also find the slides for today's presentation on our Hub website. During the webinar today, we'll hear short presentations from Tom Betlach, a partner at Speire Healthcare Strategies, from Carolyn Ingram, Executive Vice President for External Affairs at Molina Healthcare, and Jennifer Barron, Senior Strategist for Policy and Product at Cityblock. After each speaker's presentation, I'll lead a short facilitated discussion, and then we'll use the last 15 minutes of our presentation to turn to audience questions. So please keep the questions coming, and we'll get to as many of those as we can. Our first presenter today is Tom Betlach. Tom is a partner at Speire Healthcare Strategies and a former Medicaid director for the state of Arizona, where he served in that position for 10 years. Tom also served as both vice president and president at the National Association of Medicaid Directors and currently serves on the board for the National Committee for Quality Assurance, NCQA, and is a member of the Congressional Budget Office Panel of Health Advisors. Then we'll hear from Carolyn Ingram. Carolyn is the Executive Director of the Molina Cares Foundation and is also the Executive Vice President of External Affairs for Molina Healthcare, leading policy, regulatory affairs, policy relations, and branding across Medicaid, Medicare, and the marketplace. Prior to Molina, Carolyn was the Senior VP at the Center of Healthcare Strategies, a Medicaid policy think tank, leading the Medicaid Leadership Institute, a leadership program for Medicaid directors. Early in her career, Carolyn served as the Medicaid director in New Mexico for 8 years, where she developed and implemented New Mexico's first MLTSS program. Finally, we'll hear from Jennifer Barron. Jennifer is a senior strategist with Cityblock Health, and prior to joining Cityblock last month, Jennifer was a senior advisor and founding member of the CMS Medicare-Medicaid Coordination Office, where she helped develop and implement the duals demonstrations under the Financial Alignment Initiative and partnered with the CMS Innovation Center on policy issues impacting dually eligible individuals. Before CMS, Jennifer led the healthcare team at the Institute for Strategy and Competitiveness based at Harvard Business School and worked in city government and for a global health advisory organization. With that, let me turn it over to Tom to lead us off.
Thanks, Darren. It's great to be with everybody today, and certainly love talking about the topic of duals, and such an important topic, and really has so many opportunities in terms of looking at ways and strategies to improve care for the dual eligible population. So just a reminder, I would imagine most people on our call today, thanks so much for joining us, are well aware that there's over 12 million individuals that are enrolled in both the Medicare and Medicaid program, that on the Medicare side, dual eligible members represent roughly 20% of the population, but approximately 34% of the spend. On the Medicaid side, dual eligible members represent about 15% of enrollees and about 32% of the spend. So you see it's a more complex population just in terms of spend. And what this slide denotes is the complexity from various different needs of that population. So almost 40% require long-term services and support, so some institutional level of care, whether that be in a nursing facility or in the community receiving home and community-based services. Again, almost 40% also have a diagnosed behavioral health disorder and need, so significant need in terms of the dual eligible population for behavioral health services. Finally, in terms of the dual eligible population, you see almost 70% have been diagnosed with 3 or more chronic conditions. And we know that the dual eligible population is not a homogeneous population. We have a population that has a lot of different dynamics and complexities associated with it. There's the group that has aged in, that's over 65. There's a large percentage of individuals that are under 65 and become a dual eligible member as they've qualified as a result of a disability. And so, states, as they're thinking about dual eligible populations, managed care organizations, provider organizations, they need to recognize that from a strategy perspective, from looking at the complexity needs of this population, you can't just have a single approach. You've got to recognize that there are different needs associated with the dual eligible population. This next slide highlights the fact that there's clearly challenges associated with the duals. We know there's no financial alignment, there's uncoordinated care, there's fragmented care just in terms of the ecosystem that dual eligible members sit within in terms of uncoordinated programs between Medicare and Medicaid. We know there's some opportunities out there in terms of financial alignment, also in terms of improving coordinated care through products like dual special needs plans. We've also seen the needs of the dual eligible population increase as a result of the pandemic over the last 2 years. So data tells us that the hospitalization rate for individuals that are dual eligible are 4.5 times those that are just in the Medicare program. So we see significant need and significant impact associated with that. So on the right-hand side, you see some of the challenges that have been experienced as a result of the pandemic with the dual eligible population in terms of caregiver supports, higher costs of care. We know the challenges in terms of delivering in-home care. While telehealth has been a great strategy in terms of replacing the needs of delivering some services, it clearly can't replace a lot of what gets delivered through home and community-based services and institutional level of care. Transitions of care have been a very big challenge. We've had the opportunity to talk to a lot of different managed care organizations. And for those organizations where the individual's in the same organization for both Medicare and Medicaid, there's a lot of opportunities to do better transitions of care. But in a managed care organization that might not even know if an individual went into the hospital in terms of testing positive for COVID and requiring more needs, doing the transitions of care back out into the community become a much bigger challenge. I also think that the pandemic has highlighted and elevated the social needs of the dual eligible population. And I think that's been expressed also in terms of Medicare continuing to look at supplemental benefit package opportunities for dual eligible members. And this has always been the case in terms of Medicaid looking at broad home and community-based supports, but the importance of meals, being able to have that transitional benefit that's now allowed for on the Medicare side, looking at social isolation and transportation, again, been exacerbated by the pandemic and clearly needs to be part of any strategy that folks are looking at in terms of tackling this problem. We've seen a number of different models that have arisen over the last decade or so in terms of how states are looking at approaching better coordinated care for the dual special needs, for the duals population. So you see some states in the darker blue have pursued alignment, by alignment working to have individuals in the same plan, or in the case of Washington in a fee-for-service model, and pursuing a demonstration. And so working with CMS in partnership to create a model in which individuals are enrolled in the same organization, and there's a lot of coordination and integration within that organization. So there's under 400,000 individuals out of those 12 million duals that I mentioned earlier that are in these types of products. The lighter blue states are those that are pursuing managed long-term services and supports in partnership with dual special needs plan. And it's leveraging a lot of different tools states have available, not only on the Medicaid managed care side, but also in terms of leveraging regulatory tools to increase expectations on dual special needs plans. And so we've seen in a GAO report that highlighted as of January 2019, there's a little under 400,000 people also enrolled in these types of models. And finally, what's not reflected on this map, but there's over 130 PACE programs out nationally that have about 54,000 individuals enrolled. So we've been able to come a long way in terms of having progress, but still have a very long way to go in terms of overall levels of integration. I won't spend much time on this slide, but clearly there's a number of benefits for when individuals can be in the same organization for both Medicare and Medicaid. There's benefits to the members in terms of reducing the complexity and having a singular organization responsible for care management. There's benefits to providers in terms of streamlining claims process from having to deal with two separate large programs. There's benefits for states that we've seen come out in published studies around improved outcomes for members and reduced costs. And then finally, there's opportunities for health plans in terms of having a more coordinated product to offer individuals and to better serve the populations that are enrolled in their program. So Darren, it's hard to cover a lot in 6 minutes, but tried to highlight some of the things that are going on nationally and the trends that we're seeing.
No, thank you. Thank you for that, Tom. You referenced various integrated care models across the country. Are there particular models that have been shown to be effective or more effective than others for this population?
We've seen some positive results from different types of models. So the state of Washington has had a fee-for-service model in which they went through the demonstration route, and they've shown some savings associated with that model. There was a study done by ASPE that looked at Minnesota's dual special needs plans and found over a 40% lower rate of hospitalization and a 40% reduction in readmissions, also lower use of emergency departments, higher use of primary care services. And so we've also seen strategies by states like default enrollment, where if an individual's enrolled in Medicaid and they're becoming a dual eligible, there's a process in which you can seamlessly enroll them into the Medicare product of that same organization. And we've seen retention rates for default enrollment in excess of 80% in several states that are pursuing this strategy. So it's still early in terms of evaluation, but there are some positive evaluations out there for some of these products.
Yeah, very, very helpful. Do you see growth in certain types of care models over the next 5 to 10 years? And if so, why?
Yeah, I do think that we'll continue to see growth in terms of models that look to build alignment where individuals can be, have a single accountable organization that's delivering both Medicare and Medicaid. And again, there's different models by which states can achieve that. But I do think that the needs associated with the pandemic highlighted the challenges faced by this population and that the fragmentation results in poorer outcomes. So from that perspective, it's the right thing to do. I also think there's more resources available to states than if you go back to like the time when you and I were Medicaid directors and we were just sort of working to figure this out. You know, the federal government through the Duals office, the Federal Coordinated Healthcare Office, and that group has been a strong resource. There's other resources available to states, including some grants made available by Arnold Ventures. Finally, I think there's a better understanding of the types of tools states have available to them. So that might be leveraging the state Medicaid agency contract or the SMAC agreement with DSNPs and how to increase expectations and accountability for DSNPs and how also to try and build more alignment in terms of those dual eligibles by leveraging some of these different tools. So I think when you put all these things together, the outcome and the impact of the pandemic, what we've seen in terms of resources available and a better understanding of the tools, you're going to see more and more states continue to pursue strategies.
Yeah, absolutely. And while you mentioned financing as a potential barrier, that there are pathways or ways to address that with the assistance of the federal government, what are some of the other barriers to implementing these models from a state Medicaid agency perspective? And if if you can offer any strategies to overcome some of those barriers, that would be helpful as well.
Sure. So I think the first one is this is really hard work, right? It's different than Medicaid. Medicare has its own set of rules, its own set of requirements, its own bureaucracy, and Medicaid agencies oftentimes don't have a level of expertise in terms of how to engage around thinking about dual eligible members through the Medicare lens. So one of the first things that we did back in Arizona was we created a dedicated staff person to deal with these types of issues, to help not only in building our alignment strategies, but looking at what was coming out in terms of proposed regulations and getting involved in those processes. So I know it's oftentimes a struggle to go to a budget office or legislature and say, hey, we need more resources because we want to be able to pursue these opportunities with dual eligible members, knowing that a good portion of the benefit accrues to the federal government on the Medicare side. But if you want to make progress, you've got to have some staff, I think, that are dedicated towards this. The second challenge is the lack of financial alignment. And so if there's ways from a policy making perspective, the federal government can streamline some of the ways to share those savings, I think that would be helpful. A third challenge is competing priorities, right? I mean, there's just so much that's happened in the last 2 years in terms of the pandemic, unwinding from the pandemic in terms of what states are facing when you look at things like redeterminations, the importance of health equity, the new opportunities around home and community-based services. But when you look at all those things, duals can actually be a strategy to address each of those, right? Duals, if I'm pursuing strategies in the dual space, that might help address some of the health inequities that I have in the system. When I look at home and community-based services, I shouldn't look at it just through the lens of pushing dollars out from a home and community-based perspective. I should step back and think more broadly about the duals and how I can potentially be looking at strategies as it relates to home and community-based services to serve that population. And then a last area of challenge, I think, is just in terms of the complexity of this, is the need to really engage in members and families and advocacy groups. And that just takes time and a lot of heavy lifting to be able to explain these types of changes in a very complex system in a simplified way. And people oftentimes, they've figured out a way to manage with a fragmented system, and they're leery of change because of what that might do to what they've pieced together. And so being able to have really meaningful, robust conversations with members, family members, and advocacy groups is really important.
Great, Tom. That's very helpful, and thank you for that. Carolyn, can I turn it to you now?
Yeah, thanks, Darren. Thank you, everybody, for joining today. Pretty excited to be able to share some of the information with you all from a health plan perspective about what integration really means in terms of things that we're able to achieve, some of the innovations, and then I want to even turn to some of those facts and figures that Tom shared with you to show what our outcomes have been around health inequities and trying to solve some of that problem related to duals. So, one of the things I always sit back and think about, I work now on a national perspective across all of our states, helping states to better understand how to integrate care for duals. But I like to go back a lot and think about the Medicaid clients I used to work with. And one case in particular, I know everybody on this line has an interest, so probably has a case that they've worked through. But one case in particular that stands out in my mind from back when I was a Medicaid director was an elderly woman who was in her 80s. And she was caring for a grown son who had developmental disabilities. He was living at home with her. He had diabetes and heart disease and other things. But she was just trying to navigate the whole system of how to deal. He was obviously both on Medicare and Medicaid, but deal with aligning his insurance programs, making sure he got his insulin every day, making sure that he took his medication for his heart disease. And interestingly, all by herself as a caregiver, she had done this, and he had lived a very fulfilling life, being able to stay at home in the community most of the time, not all the time, but most of the time, being able to meet those challenges and take care of him. But when I met with her and talked to her, she was exhausted, just exhausted. So, you can imagine being into your 80s and still caring for your children, number one, and then, as a single mom or a single person. And then number two, having to deal with all of these different fragmented systems and somebody with complex healthcare needs, while you're also trying to make sure that they continue to live a full life in the community. So what a challenge it is for some of our members to be able to struggle with those things and how they navigate the system. And that's what we think about when we step back and think about how are we going to really make this better for people in a fragmented system. And I think managed care companies that are brought in to do integrated care are doing that. And you're going to hear also from Cityblock today about what the ways that they're doing that, hitting it head on. But one of the things that's really hard is if we don't have an integrated system, you can't meet those caregiver needs. You can't work on developing a comprehensive care plan that really helps the person, not just with their healthcare needs in terms of their mental health and behavioral health issues, but also what it really means for them socially to be there in the community and living and thriving in the community. So that's one of the things that we do to navigate those challenges and to really work through things for individuals and make sure that there's an opportunity there. Molina's been participating in the financial alignment demonstrations across the most states and has the most members, I think. And so a good wealth of experience from the beginning of a fully integrated product all the way to DSNP levels. And so I'm going to talk a little bit about that today and some of our outcomes and why those have been really important for us. The other areas I think, that we're seeing is that states are really starting to look at this area and how they can have different varying degrees of integration depending on where they are with their Medicaid program, and Tom talked about that a little bit. So I want on the next slide go ahead and share with you some of the things that we see in a more integrated system. And just bear with me, I have a small technical difficulty here. Okay, well, everything comes back up. I apologize for that. So you can see on this next slide what integrated delivery really does mean in this environment. If you look at the pie chart in the top left-hand side, you'll see, we're able to better integrate both the long-term supports and services of somebody, again, helping them to live in the community, the behavioral health care needs of that person, pharmacy, which is obviously very important for this population, and also the acute care needs. We are able to really exchange data back and forth with providers on the ground, but even in fully integrated systems back with other managed care companies sometimes as members are transitioning over from one managed care company to another. But also looking at caregiver needs and caregiver support. I'm going to dive into that in just a second. We are able to do in-home risk assessments and actually go into the home and not just do risk assessments, but also right now with COVID vaccines, be able to actually deliver vaccines in the home for people who don't want to go out and aren't physically able to, but might be having caregivers come into their home, and so they might be at risk for some type of COVID. It's also a way for us to determine how to address those social determinants of health. So whether that's food insecurity, or again, being able to help people integrate back into the community, and also the issues around isolation and really making a change to trying to get people not to feel so isolated, which can then have other triggers or other events happen for them if that's not addressed. And then the other big one that saves money for the states is really around the transition of care issues and making sure that things are coordinated when people come home from the hospital so they're able to stay in the community, or if they go from SNF level of care, skilled nursing home level of care down into a nursing home level of care, they're able to, and then eventually back into the community, that those things are all coordinated in some way. So it's really looking at the member in a holistic manner, not trying to address just one issue, but all of the needs of the member and helping it to be easier for those caregivers and other people to be able to navigate. So one of the programs that we've started in that regard, you'll see on the right-hand side of the slide, and there's some pretty impactful numbers there, is really what we call a transitions of care program, and working on helping people to move through a transition if they are institutionalized or coming out from a discharge, and really helping them to transition back into the community. COVID and even beyond before COVID hit, we saw really a need for food nutrition as being a big issue. But once COVID hit, it became kind of almost the extreme issue that had to be addressed almost immediately in every single one of our markets for a lot of our high-risk members. So we launched this program and started making sure that we were able to provide members with culturally appropriate and medically appropriate tailored meals 2 times a day to really make sure they had access to food security. And just looking at data from a 4-week period from one of our plans, we were able to significantly reduce the occurrence of inpatient hospitalization and decrease some of the medical spend. We then started to look at that impact over the next 6 months, and you can see the numbers there on the right-hand side about the decreases in costs for hospitalization for those people who were followed and participating before they were given the meals and the nutritional education, and then after. You can see there the decrease in the medical spend, down 39%, and hospitalizations decreased by 70%. But if you also look at the members who are getting the services, we kind of dug a little bit further, and we saw a lot of the members were African American or Latino and or Hispanic, and we were really able to decrease those hospitalization stays of those members as well. And I think what we are seeing more and more, and this is something obviously a lot of people on the phone know, but we have a much higher food insecurity problem in our population with minorities or people of color. And so being able to address that and really start to look at how we can reduce those costs, not for the state, but also how can we go about making sure that those folks have what they need to be able to live in the community, and how important that is to help assist with that. I think looking at integrating care for duals has really brought this to the forefront more than we had seen in some of our other populations. A pretty interesting outcome from this one piece of work in terms of integrating care, and just the effects of just making sure people had meals, I think is pretty significant. On the next slide, I just want to talk a little bit about what a fully integrated care program can mean also to caregivers. And I go back to the example that I gave you at the beginning of an elderly woman trying to care for her adult son with disabilities, and how difficult that is. And we have that and see that in all of our populations. So one of the things that we've been doing under the alignment demonstration is really making sure that we're giving out that caregiver support to our member caregivers, so that we're able to make sure that members, frankly, stay in the home or stay in the community, because they need those caregivers to be able to do that, so that the caregivers don't get burned out in some way. And also, frankly, the caregivers are often the ones that understand the needs of the member the most. They're able to help give us insight into what the member might need at home to keep them there, to be able to, so that they can stay, whether it's medical benefits or trying to figure out their pharmacy benefit, or maybe it's making adjustments or changes to the home so that the person is able to operate and function there in a high-quality manner. And so they really give us kind of our lifeline back to the member in the home. And this was very important during COVID, because you recall at the beginning of COVID, we had to shut down doing our in-home visits. We had to shut down doing our in-home transition of care planning. And so we were left with really having to rely on caregivers who then were under an increased amount of stress. So to address that, we really started to offer supports in the care planning process, not just for the member, but also for the caregivers. What did they really need to be able to continue to give that support back to people in the community to help them stay there? Was it respite for a few hours so that maybe we brought in nursing care? Was it, a benefit of having a group, a therapy group that they could go and talk to address what they are having to deal with at home in terms of being kind of a long-term caregiver for their loved one? Or is it trying to get them other tools that they can use in the home to make it a little bit easier? So we were able to go ahead and put together those care plans and really start to look at addressing that caregiver support and need. We've done the program in a couple of our states as a pilot, and it's now starting to expand out to other parts of the community. So we're really excited about that. So with that, Darren, I think I'm going to wrap up so that we don't run out of time, and I can, of course, address issues when we get to the Q&A period. I want to make sure we get to all of our speakers.
Yeah, absolutely. But I do want to follow up with a question. You talked about fragmented care, and appreciate the story that you shared. But where do you continue to see opportunities to reduce that fragmented care for these members? You know, whether it's in an FAI or a DSNP program, and you know, to the extent you're developing any new initiatives or programs to support those members, that'd be helpful to know as well.
Yeah, I think the financial alignment demonstrations and the FIDE SNPs that are out there have really gone a long way in terms of integration, but there's a lot more that we can do. You know, there's not, I think, as much as we'd like to say, you know, a fully integrated model in the financial alignment demonstrations or in the FIDEs. There's still work to do from there, and then also take that into other models like DSNP models. So, for example, just sharing data. That's one piece that, you know, a lot of states are starting to require of their managed care companies to share that data back and forth or with providers out there. But I think we also need to increase these models across the continuum. You know, the financial alignment demonstrations are only in a few states, really, if you look at it, and we can take the learnings from that and grow that into the DSNP models. And I think one area, for example, is just around enrollment. Under the financial alignment demonstrations, we've been able to see that passive enrollment actually works and can be done effectively and still meet the needs of the member and the family in an effective way. Well, we could start to integrate that model a little bit more heavily into our DSNPs. I know a lot of states, and Tom might want to talk a little bit about this. I know he's got experience in this area, but are looking to some of those automated enrollment type processes. And this is something I think that CMS can even change in the future. And even as we start to look at the PHE going away, you know, people who are dually eligible become eligible because they're eligible through SSI usually, and that eligibility is pretty stable. So asking CMS to issue temporary guidance or regulations that allow the dually eligible to stay enrolled as the PHE is being rolled out, I think is a very reasonable request. You know, give them an extension of a year to get their eligibility done is a very reasonable request for this type of population, and one way that can go a long way to encouraging those people to be in further integrated programs.
Well, thank you for that, Carolyn. Really appreciate those recommendations. Jennifer, can I turn it to you now? Jennifer, you may be on mute.
Thanks so much. Sorry, technical difficulties. I appreciate the chance to talk with you today, and thanks to everyone for joining. And what Carolyn and Tom were just sharing really resonates quite deeply with me as well. As Darren mentioned, this is my second month with Cityblock, and I'm coming to the Cityblock team from the Duals office at CMS, where I spent a lot of time thinking about the strategies states can use to integrate care for duals and the problems that health plans that serve duals face when Medicare and Medicaid aren't aligned and the plans are responsible for only a portion of their care. So what I'm excited to be doing now with Cityblock from a provider perspective is, you know, think through the interplay between policy and practice and including the broader policy landscape in which we as a provider operate and Medicare and Medicaid alignment and integration in particular. So just a little bit about Cityblock. We were founded 4 years ago to support the goal that everyone should have good care for what matters to them. And we work in particular to deliver better care to people living in lower income neighborhoods. Our members include Medicaid enrollees, people who are dually eligible for Medicare, and other people who are living in areas with poor access to healthcare services. Our first partnership was in New York with Emblem Health, which is the largest not-for-profit health plan in New York. And we are serving individuals there in New York City neighborhoods that are facing high poverty rates and all of the social challenges that accompany that. Since then, we have started serving members in a number of other markets. We are in Massachusetts, Connecticut, Washington, D.C., and we just launched a partnership with Blue Cross of North Carolina this past summer. We are also really excited to be launching another new partnership with Molina in Ohio next year, and that'll be in Cincinnati and Cleveland and Columbus. A little bit about our care model. So Cityblock integrates primary care, behavioral health, and social services to improve health in the neighborhoods that need it most. Really at the core of our care model is our belief that healthcare is local, health starts at the neighborhood level. And as we all know, so much of what goes on in our daily lives just really affects our health, like managing work and family responsibilities, having access to basic necessities like housing and food and transportation. And so we partner with local organizations in our markets to connect our members with social services that address these social factors that impact their health. The members then work with their integrated care teams to get what they need and that they want. Those care teams are flexible and based on individual members' needs, but they'd include primary care physicians, nurse care managers, psychiatrists, behavioral health specialists, community health partners that help coordinate their care, and others. Our care teams are flexible. They will meet members wherever and whenever is convenient. That may be at their home. I think I saw a question come in about home-based primary care, so that the care delivery may be in a member's home. It could be at a Cityblock center, which we call neighborhood hubs, though less certainly during the COVID pandemic. We communicate with our members by phone, by text, by video, generally multiple options of the above. And our community health partners, who are the care coordinators that help to coordinate members' care, they are really at the core of our care model. They're hired from the communities where our members live. They're often more relatable to our members than clinicians and have been really effective in working together with members to help create care plans, or we call them member action plans, that are based on each member's goals and then helping to connect that person with the right care and services that they need and want. So Cityblock, we use our care model to get to know our individual members and their circumstances. We can help to tailor the care plans together with them to meet their individual needs, since our members' needs are quite heterogeneous. For example, somebody who is socially isolated might be showing up at the hospital for reasons that are pretty much unrelated to clinical needs. As Carolyn and Tom, I think, also mentioned, this has been a particular consideration during COVID, especially. And for members that are experiencing social isolation, our care teams can and do focus on non-clinical engagement quite a bit. They'll connect that person with the appropriate social services, and they will have regular contact, as they would anyway, but even more contact with their community health partners from their communities, and that can be extremely helpful as well. And then, in contrast, somebody that is a Cityblock member who is medically complex and has significant physical health needs, like somebody who has multiple chronic conditions that may not be particularly well managed, that person might benefit most from things like medication management, maybe connection with behavioral health services, and then in addition, often to a connection to any needed social services. So our care model has a lot to offer in any environment, but really a sweet spot for us at Cityblock is an integrated plan that serves complex duals. That's one of the reasons that I'm so excited to be here talking with you today. With an integrated plan and integrated model, the plan's covering all of their members' Medicare and Medicaid services, and due to a capitation arrangement that includes both Medicare and Medicaid pieces, the plan then has flexibility to provide additional high-value services for that member, and that includes services addressing members' social determinants of health needs. And as a provider partnering with a plan that is focused on whole person health, that really sets us up for success. In terms of care integration, where Cityblock is responsible on a capitated basis with our partners for the full set of services, and the plan partner is as well in an integrated plan partnership. This just really sets the stage for us to all be focused together on whole person care and coordination across the full set of services, because they're all under the plan's responsibility, and then by extension we are accountable for them as well. Tom also talked about earlier, and Carolyn too, integrated plans also offer financial alignment. Because they have responsibility for both Medicare and Medicaid services, that just it shifts the focus to value across the whole spectrum of care. That's really payer agnostic and not dependent on whether they're Medicaid or Medicaid services in isolation. Our investment as a provider in services that are often traditionally Medicaid, like LTSS, that improve health outcomes, but outside of an integrated care model would create savings that accrue to Medicare, can in an integrated model accrue to our plan partners and by extension to us. And so that just aligns everybody's incentives the right way. It creates a cycle of reinvestment in integrated care and services that people really need and want. Again, that's just payer agnostic and in a way that's not possible in the fee-for-service system. And so in that way, our interests and our plan partners' interests, and most importantly the members' interests, are all very much aligned. I will give one very quick example of how kind of financial alignment can help better serve members. In a COVID context, we would have flexibility to put a member who may have tested positive for COVID but is also experiencing housing insecurity in a hotel, so that they can recover in a place where they are not exposed to other people. And then, more broadly than that, outside of a COVID context, we work with our members who are experiencing housing insecurity with them to develop goals around housing and to help connect them with any available housing support services if they want them. And so I can stop here, turn it back to Darren, and look forward to discussing any of this further in the Q&A. Thanks so much.
Thank you, Jennifer. Really appreciate it. A couple of questions probably before we turn to the broader Q&A. As you're describing your model, what does Cityblock do if a member already has a relationship with a PCP? Do they have to switch?
Yeah, that's a great question. Our care teams can accommodate either. Our model can accommodate either. So we can serve as an attributed PCP if members have a Cityblock doctor, or we can wrap around existing PCP relationships, whatever the member prefers. And our care model and our supporting technology are flexible enough that we can kind of adjust between either type of relationship. In cases where our members do choose to keep their existing doctors, we can bring a range of capabilities depending on the member's needs. We can provide after hours and in-home coverage to kind of support that existing physician relationship, and access to our technology platform, our Commons technology, does allow communication between members and both their Cityblock and non-Cityblock providers, as well as across Cityblock and non-Cityblock providers.
That's super helpful. Obviously, that flexibility is needed given the diverse nature of the population. How do you at Cityblock, how do you think about success?
Yeah, so that's a pretty simple one, so I can be really brief there. Success from our perspective is really also from the member's perspective, like how do they define it, what do our members want, what do our members need. As I mentioned, and Tom mentioned as well, our care model is based on an understanding that our members and low-income individuals are not homogenous. They're not a homogenous population. And so, in all cases, we'll consider whatever needs our members may have related to social determinants of health along with any clinical needs, and work to connect our members with any services they desire. But, for many of our members, the needs that they prioritize may not be what many healthcare providers might consider to be their primary medical needs. And, our care model respects that, and, the needs that our members prioritize need to take precedence.
Great. Thank you, Jennifer. Now we're going to turn to the questions we received in the chat box. And by all means, please keep those questions coming. First question, and Carolyn or Jennifer, either of you or both of you may have a comment or perspective on this. Where does home-based primary care fit into the continuum of care? Jennifer, you touched on it ever so briefly and sound like your accommodation of it, but where do y'all see that, short-term, longer-term, its role in serving this population?
Yeah, this is Jennifer. We definitely include home-based primary care as part of our care model. We also offer mobile integrated care, and that kind of extends the reach of our care teams in a number of different ways into people's homes that are not limited to primary care, but does include that. We also offer facilitated primary care, and so A local team might go to a member's home to do an in-person physical assessment and actually then connect with the member's care team by video to ensure that there's continuity with kind of our care team that might be going out and kind of the member's regular source of care. So wanting to make sure that continuity remains a high priority. But absolutely, home-based primary care and other types of clinical services are very much a part of our care model.
Carolyn, do you have thoughts?
Carolyn, I don't want to belabor the point, but I think we're doing very similar things to what Cityblock is doing. So a couple of examples right now, I mentioned, I think in my presentation, we actually have our care coordinators going back into the homes now. And so, with COVID-safe precautions and vaccinations and those types of things, but not to address the primary care issues, but actually to do, delivery of vaccines. And one of the best models I think I've seen is some of our work in California where, depending on where the member lives, some of our don't really live at home, and some of them live out in California in the street, for example, or under a bridge. And so we actually have staff that go there with their laptops, with their iPads, to meet the person where they are, to be able to address their medication needs. And then the physician dials in, and they have a meeting there together with the nurse, the member where they might be living, and then the physician on the iPad so that they can go ahead and take care of the issues that are identified right there. And then the nurse stays behind to be able to make sure to help the person follow up with where to get the medications if they need them, if they need food support, where to get that done, and then, of course, start to talk to them about housing if they're interested in that, and how we might be able to help that, or link them back to mental health and behavioral health services. And so I think that model, of what the home means to people is different for different people, and so we try to meet them where they are and their needs, and then try to get them into something that's safe and secure so that they have an improved quality of life, if that's what they desire.
That's helpful. Thank you. Another question from listeners. How do you propose improvement of continuity of care, particularly for patients with Alzheimer's or progressive dementia? Throw that out to the group broadly.
I can start, Darren, and then go ahead, Carol.
Oh, go ahead, Tom.
I was just going to say, I was going to hand it off to you and Jennifer, but basically say that, Medicaid has the expectation, at least in states that are MLTSS, that there's the full continuum of services, and as people require a higher level of care, then both the plans are working with providers, and then if an organization like Cityblock is involved in terms of doing care management and the full array of care services, then as an individual requires a higher level of need with regards to dementia, then those services need to be delivered as the individual requires that. Carolyn or Jennifer, I don't know if you want to jump in and add more to that.
Yeah, I think I'll go back again to a couple things. Our goal is to make sure people live safely in the community, and if that's possible. And so patients with Alzheimer's or dementia or progressive dementia, that takes special requirements. Again, our staff go out into the home to make sure and assess, can the person live safely there, and what things, if they can or can't, what things do we need to help put in place. And sometimes that is helping with making the space easier for somebody to live in. If they really can't be secure in that type of environment all day long because the caregiver has to work or has to be gone from the home, what can we do to provide support during the day where the person might be able to go to an activity in the community that does provide that safety, and then be able to come home at night so that the caregiver can still be there at night with them and taking care of them. So again, on an individualized basis, that's definitely part of the care planning process. And what goes into it is as individuals age and have to transition, to different levels of care. But again, the first goal is just to help hopefully keep people in the community. And not all of our members can do that safely. And if they can't, then we have to go ahead and assess if they need to move to a higher level of care in order to have that safe environment for them. And then, I mentioned in my presentation really the caregiver support, but that's really key to making sure people can stay at home in the community with dementia or with Alzheimer's, because somebody does generally have to be there to help them and to provide that support.
Yeah, and I would just echo what Carolyn said. I don't have a whole lot to add beyond that, but just to reemphasize as well that from our perspective, partnering with an integrated plan and having kind of that flexibility to be able to use every tool in our toolbox, regardless of payer, to be able to help support our members and our health plan partners' members in the community is much more helpful when we have kind of an integrated plan partner and a capitated relationship. So that just really provides flexibility to allow us to provide services that will help support our members with Alzheimer's or dementia, but just more broadly.
Well, and one other thing, Darren, just to expand on that, it just came to mind is we're also providing support, and this is actually through the foundation. So I'm just take off my Molina hat for a minute and talk about our foundation. But our foundation is actually helping the state of California to set up some echo clinics in California with the Alzheimer's Association there, so that they have the ability to go out into the community and train providers in areas to deal with dementia and Alzheimer's, so that those providers are also better able to meet those members' needs. So we're really excited about, from the foundation's perspective, being able to launch those echo clinics with the Alzheimer's Association in California in partnership with them. And I think that's another way, that you can see infrastructure being built. We're not the only foundation doing that work. I think at the beginning of the call, Tom mentioned about the Arnold Fund also contributing a lot to work around duals, and so does the SCAN Foundation and Commonwealth Fund. But something interesting there that states who are on the phone listening, if you're not getting the technical support that you need, there's lots of different places to reach out, including your foundation. So thanks, Darren. Back to you.
Yeah, totally. I appreciate that, the supporting of the communities and the providers and enhancing their capabilities. But I think your comments about caregivers' natural supports and supporting them as well is critical. As my grandmother had Alzheimer's, and I saw where that played a big role. Our friend Camille
Darren, we also saw states experiment with some demonstration authority too during the pandemic, where some states were offering spouses as paid caregivers as well. And we'll see what happens sort of as states unwind some of that authority and what stays. But I think that, it sort of resulted in states being creative in how to think about some of these issues.
Yeah, fair point. Thanks for bringing that up. Jennifer, Camille Dobson, a friend of ours, she asked a question specific to you. Does Cityblock ensure compliance with Medicaid requirements for HCBS services, for example, planning, network adequacy, et cetera? And so how does that reporting to the state work with an integrated health plan partner?
Yeah, and so we are everything we do really rolls up to the plan. So we're a provider in the plan's network, and our preference is to be a full partner and a fully capitated partner, and take total accountability for Medicare and Medicaid services. But the reporting and kind of the direct relationship with the state would roll up to the plan. So we would take on whatever requirements that they have for what we provide, but ultimately it's the plan's responsibility to ensure network adequacy and report to the state.
Great. Tom, I'm going to ask you this question. How do states, plans, and CBOs engage dual-eligible individuals to receive input on the model design and improve the programs? What's working and what's not?
Yeah, there's clearly some areas that work well. One is to look to see what's out there already existing in terms of infrastructure for engaging members and families. So oftentimes managed care organizations may already have that type of connection in place, leveraging groups that have been compiled by the AAAs or SHIPs or others as well, in terms of partners that you can work with. Bringing in experts in terms of organizations that deal with member engagement on a regular basis, I think, should be part of a comprehensive strategy to be able to look to those that are really, have the expertise around strategies. Carolyn mentioned this already, but having strategies in place in terms of meeting people where they are in the community. And so, being able to go out and identify those different places where you can engage. And then I think the other important area is just being thoughtful around the communication strategy in terms of the messaging that's being provided. Clearly, you want to be able to be thoughtful in terms of how you're garnering that feedback and what's important and understanding that back from members and families, but also being able to offer some simplistic messages around something that's very complex, right? So oftentimes we speak in acronyms, we speak in a language that's really not conducive to having a good dialogue with individuals that are part of the system. And so if we really want a system that's informed and truly get people's lived experience in the system, we've got to be able to simplify our communication.
Thank you. And I think given our time, we have one final question. Do any programs utilize the 4 M's in assessing members? What matters, mobility, medications, and mentation? It's an effective tool by the Hartford Foundation for developing an age-friendly health system. Do any of y'all aware of programs that are using that approach?
Thanks, Darren. This is Carolyn. I'll go first. The assessment tools I think that probably most managed care companies use, so I can speak for Molina, but all of us, I think, use these tools, look at these areas. So you start with what matters most in terms of what is important to keep the individual in the community living there, what are their goals, what do they want to achieve. A lot of that does come then back to the mobility for the person, medication management and how that's handled and dealt with, and then also just around mental health and inclusion. And I know I keep sounding like a broken record, but this has been more evident if anybody has ever seen it, in any population, but for our dually eligible population during COVID. And, I can't talk to you enough about the cases that we deal with where people have been isolated. So of products that we are now launching, testing out in states, actually Arizona is one state, but some other states as well, where we are offering different tools and technology to help with some of that isolation. So where family members still feel nervous about COVID and can't travel, or maybe there's issues around vaccines or these variants that we're now experiencing, being able to offer electronic tools, whether it's through televisits or mobile apps that connect people back to their care coordinator so they're able to get that connection or report in, yes, I took my medication today, I'm feeling depressed, or these are some of the issues. And so all of that goes into the care planning tool as we're trying to, again, help people live out in the community, along with the other pieces I mentioned around food security, safety, and caregiver support. And I think any of us would be doing a disservice to our members if we didn't look at those pieces across the board. And I think our Medicaid agencies expect us to do that. And, again, just a plug for when we start to come out of this COVID period and remove the PHE, what I would encourage any states or advocacy folks on the line to think about is making sure to advocate up to CMS that these pieces are so integral to a person who's on Medicare and Medicaid that we need to keep that eligibility going during that redetermination for people so that we're able to continue the support and not risk somebody falling off the program to get those services.
Well, I want to thank you all. Thank you to our speakers, our participants, and sponsors. Really appreciate it. Also would encourage folks that are looking to access the slide presentations. I have up the slide where you can find that at the NORC website. And also would encourage others to participate in our future webinars in this series that we will be scheduling here soon. Thank you all. Appreciate it. And this concludes our seminar for today.